Afternoon, everybody, and welcome to the CEIH Improvement Showcase. Today we are in Series 6, Hospital Avoidance Strategies, and we're really excited to welcome Jeanette and Ryan Lovett from Wellbeing SA to talk with us today. My name's Katie Billing. I'm the Executive Director of Consumer and Clinical Partnerships at the CEIH, and I have the pleasure of hosting the session today. Before we get started, I would like to acknowledge that many of us are meeting on the lands of the Kaurna people, and that myself I'm in the lands of the Pemamung people up in the hills today. Acknowledge that we respect the spiritual relationship with country. We also acknowledge the Aboriginal people as the custodians of the lands and the waters on which we meet, and that their cultural and heritage beliefs are still as important to living people today. I'd also like to welcome Aboriginal and Torres Strait Islander people who might be present in our sessions today. I guess to start with, it's important for us to just talk about the CEIH briefly and why we're here. So the CEIH's vision is together, let's create better healthcare for all South Australians. It's really about how we do things together and how we collaborate and start to work together. And let's is also about that idea that we can't do anything on our own. We actually need to bring others together to create. And when we're creating, I guess it's not about making, it's about creating. It is that sort of reflection of how we do things that are in that creative space and are in that space where we're using our imagination. We use the term better in our vision quite deliberately, and that's because we can measure better. If we said excellent, it's really hard to be able to say, actually, well, what does excellent look like and how do we know we've achieved excellent? But by saying better, what we're indicating is that we're actually on the track and that we're able to measure that we're heading in the right direction to make things better for South Australians. Healthcare is our patch, that's where we work. Wherever there is healthcare provided, that's where you'll find us. And that means that our remit is really broad across the healthcare system, whether that's from your GP or your local pharmacist, right through to our acute care sector in both the public and private system. The CEIH brought together this idea, I guess, of, what if the big idea is connecting all the small ideas? And for me, as someone who's worked in the health system here in South Australia for a long time, I really am just frustrated, I guess, by this notion that we don't necessarily know what's happening just down the road, and we don't always take the opportunities to connect and to share. And so today's session is a fantastic example of really just knowing what's going on. The session today will be a recorded presentation so that we can make the presentation from Jeanette and Ryan available on our YouTube channel and promote that after the session. But at the end of that formal presentation, we will open up a Q&A that won't be recorded to give you all the opportunity to actually connect and collaborate in real time straight after the presentation. So we get really excited about that. And if you're watching this on video, it'd be great if you can join us live next time so that you can join in that conversation. Really importantly, we'll just get you to do housekeeping to keep your mics on mute. Cameras on's great for the presenters because then they can tell that there's actually some bodies sitting in the chairs watching them at the other end. And that obviously that doesn't work for everybody. Really glad that you've been able to join us, and we appreciate you connecting with each other here today as well. So the Improvement Showcase, we host Thursdays at 1 o'clock and then online whenever. And the idea is bringing healthcare teams together, providing a space to explore what others are learnt and keeping it simple. This isn't about what have you published and how many times have you been cited. This is about how can you just share where you're up to. Really importantly, we want to hear from you if you've got a story to tell. Have you succeeded in solving a problem, or have you learnt something whilst trying to solve a problem? Or are there themes that you'd like us to explore in the future? Please get in contact with us at ceih@sa.gov.au. So without further ado, I'd like to introduce today's presentation, which is the consumer perspective in the design of Wellbeing SA Hospital Avoidance Services. We're very, very privileged to have both Jeanette as the Executive Director of Integrated Care Systems and Ryan Lovett as the Program Lead for Hospital Community Integration from Wellbeing SA here with us today. I'll hand over Ryan and Jeanette so that you can share your screen. And we look forward to having a bright and exciting conversation afterwards.
Excellent. So thank you very much, Katie. Jeanette Walters here, Great to be talking with you all today. And I'm going to kick off the presentation, which I think is a really, for me, a really interesting topic and something that we're really keen to share our small idea, hopefully with a lot of others who work in particularly the in-home care space, because we think it's really important that we listen to the voices of our community that we're here to serve in making sure we're doing that in a way that's appropriate and well designed for their needs. But let's start off with a little bit about Wellbeing SA. So next slide, thank you. So Wellbeing SA, if you don't know, is an attached office, a bit like CEIH is to the Department for Health and Wellbeing. So we're an independent government agency with a focus on prevention. And we use a population health approach to look at prevention across the whole continuum, from taking a view about primary prevention, promoting wellbeing and preventing risk factors, through to secondary prevention, identifying risk factors and doing something about those, through to our area in integrated care systems, where we focus more on people with established disease to ensure that they can receive better care closer to their home and community. Next slide, please. So as you can see here, we have a range of different initiatives that we deliver. You may have heard of some of them: priority care centres, My Home Hospital, SA Community Care also sits within our remit, and quite a lot of work that we do supporting people who are in hospital but cannot be discharged to the community because they're awaiting services, particularly from the NDIS, and we do a lot of work in supporting them in that space as well. Health pathways might be an area that you're familiar with, and that supports general practice in being able to understand and link easily to good practice in the management of chronic conditions and other conditions to be able to keep people well managed in the community. So next slide, please, Ryan. So here's a little snapshot of what we've been up to over the past year and almost 2 years since we've been established, and quite a lot of different spaces that we've been working in. Next slide, please. A couple of initiatives that we really have developed since becoming an attached agency are the priority care centres, where we've seen over 23,000 people in these settings, which provide a safe and effective alternative for people requiring urgent but not emergency care. So instead of going to an emergency department, they can receive that timely urgent care in the community setting. And you can see some really great information there about the satisfaction of patients in that setting. And we've done quite a lot of work with people in understanding what it is that they need from that kind of setting and why they might go to an emergency department rather than general practice. Next slide, please. We've also established My Home Hospital, which delivers acute care in the home, in a hospital in the home setting. Again, a large number of people have been through that, and you can see a high level of satisfaction in those services. This brings care in the form of the nursing, medical care, imaging, pharmacy, and is underpinned by a really robust platform of monitoring that can be done virtually. So that supports people getting that 24/7 support, but staying in the comfort and familiar surroundings of their own home. The youngest person has been 17 and the oldest 103. So we've really spanned the whole age range, and quite a large proportion of people in residential aged care settings. So it's been really positive to see that growth. So I guess the question here, and next slide, Ryan, is how did we get here how did we design services that did have such a high level of patient satisfaction? It wasn't incidental. It has been by design, and it's something that we thought would be really interesting to people if we shared a little bit of the journey of how we did that, but also what we learned, because I don't think that the things that we learnt through our process are exclusive to My Home Hospital delivering care in the home. I think they're really interesting things that are transferable to a whole range of in-the-home services. But I'm going to pass over to Ryan now, who's going to talk in a little bit more detail about My Home Hospital and largely the co-design process that we used to engage people in that process.
Thanks, Jeanette. Yeah, absolutely. I think My Home Hospital tells a really great story about kind of our experience with co-design. And My Home Hospital, we admitted our first patient in January of this year, but in the months and years before that, we had done a lot of work to make sure that on the day that first patient was admitted, that it was a great experience from day one, and that we had considered as broadly as we possibly could the needs of the community and the patients and the consumers in the design of the service. So Jeanette's given a brief overview of My Home Hospital. So it is a public level hospital service. So it's the same as any of our traditional hospitals that are managed by the LHNs. It comes at no charge to patients. So people, when they hear the fact that we have a service provider, which is Calvary Medibank, they think they'll have to be a private patient. That's not the case. It is a public hospital and comes free of charge to eligible public patients. And like a traditional hospital, we operate 24/7. And at the moment, our footprint spans the Adelaide metropolitan area and the Gawler hospital catchment, and we'll be very excited to bring that service into the hills in the near future as well. And like a public hospital, everything that's required for that episode of care is brought to that patient through My Home Hospital. So that includes, as you say, all medications, any medical equipment that might be required, any diagnostics and things like that. So it's an acute hospital level service. And that was the tricky bit that we really wanted to focus on when we're talking with our potential consumers. So we started very early about talking about co-design. Wellbeing SA has an innate commitment to working with communities. And so that really was kind of spread through the entire process from day one. So very broadly, we did a lot of targeted engagement, and this includes going out and talking to people in priority groups, talking to consumers, and really getting an idea of how they see the service and how they would like the service to be designed. We then moved on to a series of co-design workshops. We brought together clinicians, key stakeholders, consumers again, and we went through and kind of articulated some more how those design principles and how that co-design might work and how that service could be designed. And then we did some targeted engagement, which is ongoing with some very specific groups, which I'll talk about later in the presentation. Then we get to today, where we're, as Jeanette said, 1,300 patients into the service and a very high level of consumer satisfaction and with the service. So we kind of started, as it says here, back at this time a year ago. And we went out and started just talking to people. That was the first thing we did. So we engaged the services of an organisation called Democracy Co, who helped us with this, and they're experts in kind of engagement. And I'll talk a bit more about some of the work they did with us later as well. And we went out and started by talking to people with lived experience. So it was keen for us to understand of people that have experienced care in hospital, but also home-based care, what their experience was and what kind of their takeaway from those experiences were. We then went and talked to some specific priority care groups. So we talked to carers, we talked to residential care providers, we talked to people living with a disability, we talked to culturally and linguistically diverse communities. And so we really went out and with these specific and more, there's a long list of these priority groups that we wanted to talk to. We really want and get their perspective. So carers had a very specific perspective on how the service could be provided. People who may not be fluent in English to the point where if somebody's talking to them about medical matters, but how can we kind of design the service to support them and make them feel safe and supported? We then did a general community workshop where we selected through Democracy Co again, selected a random sample of people from the South Australian community. That was reflective of the South Australian demographic, and again went through this same process with them, asked them questions about what's important to them from the service, what would their concerns be about receiving home-based care. And kind of this bit at the beginning led to the development of what we call our design principles. And I'll share those in the next slide. But those design principles became like our bedrock. Those were our commandments for how we designed the service from there on in. So any question that we asked about, making changes to the service, implementing, a new type of service, we always would go back and say, how does this fit in, and how are the design principles reflected in the way that we've designed this aspect of the service? And then we went into a series of workshops, of large workshops. So we had a 2-day workshop in October last year. We brought together over 150 people from across both the health system, but from also the community. And we went through a process again with them of saying, we've broken down the patient journey again, which I'll talk about. We've broken down the patient journey, and we kind of said, how can we apply these design principles at every stage of the patient journey? That led to a series of operational procedures that would inform how the service is delivered day to day by the service provider. We tested those. So we went back and tested those with some of the groups and some of the individuals that participated in our first series of workshops, some of these priority care groups, some of the people with lived experience. We went back and tested those specifically. And then that culminated in a final workshop where we had brought that information back from testing, brought that information back from all that experience, and said, right, now we've got all this, how do we look, what does it look like for day one when we start the service? And that's kind of where we got you through this process. And then we started the service, and then we entered a period of continuous improvement and continuous analysis, and I'll talk about that as well. So the design principles, the design principles were really, like I said, these were kind of our commandments for how we design the service. And these were written, and these are available on the My Home Hospital website. These are just the titles, but there's some statements that live underneath these as well. And the statements are recorded in the words of the participants from our consumer engagement workshops. We didn't edit them at all. And that really came through when we were working with clinicians as part of our broader workshops. They say, well, this is a very interesting statement. And we say, well, this is a statement that the consumer told to us in their own words. And that, I think that caused a lot of the participants to actually step back and think, well, that's a really interesting perspective that may not have been carried through some of these other design processes. And none of these are groundbreaking. They're all like things that you would expect, but it's really useful to actually say, we're going to put these on a poster and we're going to put these on a wall, and these are the things that we're going to live by. And some of the ones that were really brought out for us was very much around patient choice and around patients, carers, and clinical staff as partners in care. Those were kind of the real ones that really kind of broke through about how we really need to design this system and these processes. So here's just a couple of photos from our co-design workshops that we had in October. I see a really broad section. We've got everyone in the room. We did a lot of workshopy stuff. There was butcher's paper and post-it notes, and it was great. And because we managed to really get those perspectives from everybody in the room, and we got a really great broad cross-section of perspectives and a really great broad cross-section of how we would operationalize some of the feedback. So this is the approach we took when we're going through designing these or operationalizing these processes. So we broke the patient journey down into these 6 key factors, which you can see around the outside of the screen. And then we went through and we broke out into groups, and we went through and said, how can we design a service at each point in this patient journey that reflects those design principles? So for things like discharge was a really important one, and really gave rise to a lot of conversation about how people feel when they're discharged from the health system. They say, sometimes I will, somebody will come to me in a hospital, they'll hand me a letter from my GP, and I'll vote for my GP. They'll hand me 7 days worth of medications, and I'll be sent on my way. And I don't really understand kind of what I do next. And that was even more kind of cogent when we were talking to people with caring responsibilities, whether that be, a spouse care or a parent carer. And they said, we really want to understand what happens at those points in the discharge process. So we designed a discharge process that, at 48 hours before a planned discharge, we make contact with the family, make contact with the carers, make contact with the patient, make contact with the patient's general practitioner to make sure that everybody knows where this patient is at in their care journey, and what the journey looks like for them for the next few days, and what supports they may require on their discharge from the service. And we did that throughout the whole, as I said, the whole patient journey. And and as I said, we've worked with Democracy Co. So the output of all of these workshops we compile into a series of reports, and the one on the right, the community consultation report, is actually available as a public report on our website. So you can actually go and read, and you can read how we took that journey. You can read who we engaged with at what points. You can see the feedback in the own words of the consumers. Again, there's lots of pull quotes in there about what people were telling us along the way. There were points where, it's well documented where there were these inflection points where we really had to make a decision about how do we best design the service, or how do we go back and engage with our service provider to really make sure that that the service was reflective of that community consultation. So I've talked about kind of the target consultation. I've talked about how we did co-design, and this is a very high level, obviously, but certainly happy to answer questions and provide follow-up information. And now we're kind of in this ongoing stage now where we really want to make sure that what we heard and how we translated what we heard into a service offering, how that actually is working in reality, and are we achieving our objectives that we had around designing that service. So we're doing a whole lot of ongoing education. So the team from Wellbeing SA, and I see Cassie Ryan, who's our clinical leads on the session today, are out and talking to residential aged care facility providers. Cassie's been on Radio Italia a couple of times, talking to the members of the Italian speaking community in South Australia. We've been to general practice, and we continue our engagement education through the LHNs. We're doing a lot of work around raising awareness of the service, as is, and this is what, something that we will constantly need to do, that this is a service and an offering that's available for people. And we're doing that through community outreach and through engagement with general practice primarily. And we are engaged in the process of continuous improvement. We have a very robust commercial agreement with our service provider, and through that, we are constantly working with them to draw out information about how is the service being offered, are we reaching the clinical benchmarks that we are required to, but also the ambitions that we're setting for ourselves with the service, and are we providing a service that's responsive to the needs of those communities. So we do a lot of work around talking to people and about working with patients about doing follow-up. And so we've had a number of patients that have been through our service that have engaged in media and social media campaigns with us, who are super enthusiastic. Just recently, for Carers Week, we had a great story about a couple from Modbury who had a lived experience of the service and were able to speak really positively about how that service really supported them in their caring requirements, but also providing that acute level hospital care. We are currently looking to grow the service. So as I said, we're looking to expand into the hills in the next couple of months, and then into the Southern Fleurieu early next year. We are expanding this clinical scope of the service. So we started with a very targeted set of clinical conditions, just to make sure we could bed those in and provide that service effectively. And now we're looking to expand that clinical scope as well. And one of the things we did, which was amazing, is we came back together in May and June this year, and we brought back all of the members of our original co-design workshops, and we had a check-in, a read back of what's been happening. And in the lead up to that process, we went out to them and asked them. We did a couple of things. First, we took all of the concerns and questions and outstanding bits that we collected during the first series of co-design, which were in that report that I mentioned. And then we did another check-in with a number of people just before the workshops, and we compiled this list of questions as saying, here's what we heard from you in October, here's what we're hearing from you now, and here's what we've done, and here's what we are doing to address those concerns. And there's, again, it's a bit hard to read, but we can share some of this with you about how we've actually met. Some of this, it's all very well to speak around, we're going to do great patient discharge, but when you're 3 or 4 months out from starting a service, you need to make sure that holds water when the service has been operating for weeks and months. And so actually being able to provide back to those stakeholders, you said that you had a concern about discharge, and here's what we've done about discharge. Here's some samples of the discharge paperwork we provide. Here's some reports on timeliness of that discharge process. And that was really, and we did that across the full gamut of that patient journey, just to provide that feedback back. And we also provided the ability for those participants in a semi-formal setting to engage with the clinicians that run the service. We brought the clinicians in on the day of this workshop, and we had a number of very informal sessions where they're allowed to, where we were sitting around a table and provided those stakeholders with the opportunity to really grill those clinicians and grill the managers of the service about how they've really done this, and get into that detail and that nuance. And that was really reassuring for some of those key people. So where we're at now, so we are, we started in January, so we are, 10 months in now and 1,300 patients. But we haven't stopped. Obviously, the things need to keep going. So one of the first things, one of the things we wanted to do towards June and July is really have a look at how we managed our implementation and produce a report about how effective that implementation process was. And so in project management parlance, that's a project closure report. But for us, we went and spoke to all of our LHN stakeholders. We went and spoke again to these targeted community groups who had lived experience of our service. And we spoke to the service provider as well, and we sought some really frank feedback about how the implementation was managed, how we managed to translate some of those community voices into the service, and then kind of how we plan to work forward from that and address any of those shortcomings or things or learnings and things that we could have done better based on that feedback we got from all those stakeholders. So that's just in the final stages now of being drafted. That's we expect to get our first copy of that in the next couple of weeks so we can have a read of it. We're doing a lot of enhanced aged care engagement now. We're really going in and speaking to aged care providers. We actually piloted the service with aged care providers in December. So before we had a soft launch before we went live, with some of our colleagues there. So we just test some of those processes in the environment that was safe and supportive. And now we're going back and having these conversations with them about how's that interface working between aged care provider and acute health service providers. That was always one of the key challenges for us. So we're constantly asking those questions. Same with called communities. We have had a number of patients that have utilised interpretive services in order to receive the service, and then we're going back and having some expanded conversations with some of those specific community groups about how do we make this service culturally safe for you and for your community. We're kicking off our Aboriginal engagement in earnest now. We had it's a delayed start, and we acknowledge that, but we are now really getting in earnest into engaging with the Aboriginal health services and how we provide again that culturally safe service for Aboriginal people, and also about access to service. So obviously we have a very defined footprint, but how can we enable Aboriginal people to access our service as well? That's a real key for us. We're participating in CEIH, which is the South Australian Public Hospital Consumer Survey. So as like any public hospital would in South Australia, we're actively participating in that. And I'll speak to that in a second as well, because we did some tweaks of that just based on our consumer feedback. We do referrer satisfaction survey. So everybody that refers into the service, clinicians, nurses, paramedics, they get a survey from us to say, how was your experience with referral into the service? In the last few weeks, we sent out 207 of those just to try and get that feedback. That was for the last few weeks. We do consumer satisfaction surveys. So we offer people an online, an in print, and an over the phone opportunity to provide feedback of their experience of the service. It is a reasonably long survey, but we take people through that and say, listen, we really want to understand, especially at this stage of the service's life, we really want to understand your experience of the service and how we can improve. And we are in the process of engaging right at this minute for a formal evaluation of the service. So we'll go out to an independent third party and ask them to evaluate how the service has been provided, and again to liaise with some of those key stakeholders. So in CEIH, one of the things that came out really interesting during some of our initial engagement is there were these 6 key aspects of the service that people were most worried about. And again, it goes to cultural safety and the key aspect, and people coming in and understand the culture of people, especially in their home. And this was the real key for us. These are people coming into our home to provide service. This is our space. And from a clinical perspective, that's great, because that really puts the patient at the center of care. Whereas rather than taking a patient out of what is their space, bringing them to a traditional clinical space, a hospital or a GP practice, where there's a real shift in power dynamic, people in their own home really maintain that power within themselves, because it's their space. So it was very much around aspects of that. So cultural safety, about people knowing who was coming to their house and having those people treat their space with respect and with dignity, as it says there, about explaining how the service was going to be delivered. And then the other one was about how we engage with carers. And so how we engage with carers and families and loved ones about really providing a service. Again, because if you're in your house, you're living with your family, you might be living with a carer, you might be living with children, And so it's about how the service will support them as well in that environment. And so I'll throw back to Jeanette here. That's a very swift overview.
Yeah.
I'll throw back to Jeanette.
I'll bring it home here.
That's right.
So thanks, Ryan. And you raised a really important point in that last slide, which was kind of a touch point for us. And when CEIH asked us about what is it that we learned through this process, it was really how to put and keep people at the centre of the care, and being able to use that touchstone of, it's my home, you're coming into my home, it's my rules, rather than I'm in a hospital. When you go to a hospital, you actually conform to the rules of the hospital. In your home, does the service provider kind of conform to your rules and how you like to have things set up and run? So I think that was a really important learning, and it's something that I think brings all of our providers and our referrers together collectively about trying to produce a great healthcare outcome, but also a great healthcare experience. And I think that's been a really important part of our learning, was how to do that and how to be thinking about it being really is that patient space, and we need to respect that, and we need to learn how to do that in a way that is flexible and agile to their changing needs as well. So on that note, I think that's our talking done, and we'll hand over for questions.
Thank you so much, Jeanette and Ryan. Very grateful to you for that presentation.